You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I am Dr. Ann Cross. I'm a neurologist at Washington University, and welcome to Medscape's In Discussion series on multiple sclerosis. And today we'll be discussing some of the exciting new imaging biomarkers in MS. First, let me introduce my guest, Dr. Matthew Brier. He is an MD, PhD, and he's an assistant professor of neurology and radiology at Washington University in St. Louis. And his research combines both advanced MRI and positron emission tomography, or PET, imaging to investigate the biological processes that are going on underlying the MS pathology. So welcome to In Discussion. Welcome, Dr. Brier.
Thanks, Ann. Happy to be here.
We like to start out a little bit hearing about you. Where did you grow up? What's your background? Where'd you go to school? Predominantly, what got you interested in MS and MS research?
Yeah, sure. So I grew up in North Texas, in a suburb of Dallas, and I lived there most of my kind of growing up life. I went to undergraduate at the University of Texas at Dallas, there in Richardson. I initially started off thinking that I wanted to do computer science or electrical engineering, and got interested in the idea of artificial intelligence before artificial intelligence was cool. I reasoned to myself that if I was going to program a computer to act like a brain, I should probably take a neuroscience course. And I figured that one ought to do it, and then I would understand how the brain worked. And so I took that first neuroscience course with the arrogance that only an 18-year-old can muster. The rest was kind of history. I got much more interested in the neuroscience and the biology and much less interested in the computer programming. I was fortunate enough to work in a laboratory led by a neurologist, Dr. John Hart, there at UT Dallas and UT Southwestern, who really got me interested in the brain and instilled in me really early on the importance of clinical relevance to scientific questions. When I graduated from UT Dallas, I was fortunate enough to earn a spot in the medical scientist training program here at WashU, and I've been here ever since. I completed my PhD training with Bo Ansis, who's still here. We studied preclinical Alzheimer's disease using predominantly MRI, but that was my first introduction to PET. And then I stayed for residency and fellowship, and now I'm on the faculty at WashU, where I see patients with MS and related disorders, and then most of my time is spent running my research lab, which uses advanced imaging to try and understand MS pathology, particularly progressive pathology.
Well, we are very, very happy and fortunate to have you at Washington University, Matt. We'll just dive right in. The central vein sign, that's gotten a huge amount of attention and interest. And could you tell us what is it and what does it mean?
Sure. So one of the challenges that surrounds diagnosis of multiple sclerosis is differentiating lesions in the brain that might be due to multiple sclerosis from lesions that are due to any of the other kind of wide range of pathologies that manifest as lesions. Things like cerebral small vessel disease, other vascular pathologies, even things as common as migraines and other types of headaches can all cause white matter lesions or white matter hyperintensities in the brain. And it falls on clinicians to differentiate using clinical history, examination, intuition, whether any one lesion is due to multiple sclerosis or some other pathological process. And for a long time, we've relied on the clinical correlation, the history and the exam that the patient presents with in order to determine whether any given lesion might be due to MS or due to something else. However, as MRI has gotten better and as our understanding of MS pathophysiology has improved, we've been able to build better imaging tools to help with this differentiation. And so one of the really central observations in MS pathology is that the MS lesion begins around or tends to begin around veins. And so the The initial gadolinium contrast enhancement extravasates around the vein. That massive inflammatory response transmits through or collects around the vein. And when you look at pathology, there's often a central vein running through MS lesions. Veins are filled with blood, obviously, and the iron in that blood allows us to image veins, even very small veins within the brain. And so using one of several different sequences, you can identify the small venous structures in the brain and then ask, is this lesion around a vein? And that's very typical of multiple sclerosis, but is less typical of other pathologies such as small vessel disease, which tends to be around, for example, end arterial structures. By identifying a number of lesions that have veins running through their center, you can be fairly confident that you're looking at that a scan of a person who has multiple sclerosis or similar pathology. They may have something else also, but they at least have evidence of this perivenular pathology, which is so typical of MS.
Thank you. Are there any other diseases that cause the central vein sign, or is this specific to MS?
There are. So I think it's important to think about this sign as a statistical probability. If you have a lesion that just appears randomly in the brain, there's a chance that it's going to have a vein inside of it. What makes the central vein sign powerful for multiple sclerosis is that most of the lesions are going to have those central veins, or at least many of those lesions are going to have those central veins running through it. So finding one lesion with a central vein is not terribly informative, but finding somebody with a brain full of lesions that all have central veins through them, that's what this is about. It's about linking the pathophysiology with the imaging finding. But to your question, there are other diseases that have perivenular inflammation. Some of the atypical or less common demyelinating diseases have some predilection for venous involvement. Things like MOGAD and NMO, aquaporin 4 NMO, have some tendency. Other rheumatologic conditions, so Sjogren's disease is the one that comes to mind, sometimes also have this perivenular distribution. So it's I think, to the benefit of neurologists, we're not going to be replaced by an MRI scan, but this is certainly a helpful tool for excluding the more common confounds like vascular phenomena and things like that.
Thank you. Are these lesions, are they in the gray matter as well as the white matter, or primarily in the white matter, the central vein sign?
Yeah, that's a good question. So for the purposes of sort of clinical MRI, they tend to be in the they're in the white matter, and that's for a lot of reasons. White matter lesions are easier to visualize than gray matter lesions. They tend to be larger also. The cortex is relatively thin, and so even if you have a gray matter lesion, it may be below the resolution or right at the resolution of your MRI scanner, which makes it difficult to detect. When we're talking about central vein sign, we're talking about white matter lesions. I would almost kick this back to you, and this is, the pathology is your area of expertise. There are gray matter lesions, and they also tend to be perivenular. If we had an MRI with infinite resolution or infinite field strength, we probably could see those too. But in the clinic, at least in clinical practice, that's not what we're routinely looking at yet.
Thank you. One more question on the CVS, and then we'll move to something else.
Okay.
How sensitive is it, or maybe what proportion of MS patients actually have this?
There's two parts to that question. One is, how sensitive is the pathology itself or the pathophysiology? And that's incredibly sensitive. The MS lesions tend to be perivenular. So you would expect most MS patients who have brain pathology, you can have patients who have predominantly spinal cord pathology, and that's kind of a whole nother issue. But if you have brain lesions, there should be central veins in them. And so depending on exactly how the studies are done, the sensitivities are high. The issue that's facing us right now as a neurological community and in the radiology community is how to roll these sequences out in a way that is deployable. So it's gone from kind of a biology or pathophysiology question to more of an implementation science question of, how do you get all of the MRI scanners in the world that might scan an MS patient to be capable of running these sequences? The hardware manufacturers are quickly rolling out product sequences to allow this, but that's still kind of in the growth phase. You have to have the right tools to see it, otherwise it's not sensitive at all. So the kind of standard susceptibility weighted imaging that you might do as part of a stroke protocol to look for hemorrhage or superficial siderosis or those kinds of things is not sufficient. You need a much higher resolution, either susceptibility weighted image or T2 star weighted image in order to see these lesions. And that's where the practical sensitivity is going to come in, is whether the image is even acquired. A lot of groups that are involved in writing guidelines and diagnostic criteria are really pressuring imaging centers to be able to do this. Not all that complicated, but extra step.
So paramagnetic rim lesions, what are these and what do they mean? And are we doing them in the clinic yet?
Yeah, so paramagnetic rim lesion, or PEARL, is the kind of cute acronym that we've been using. These are lesions that are not acute. They're not new lesions. They're not gadolinium enhancing lesions. They're lesions that have been in the person's brain for a while, but show evidence of ongoing inflammatory activity. We've known for a really long time that some lesions tend to become inactive or don't show a great deal of inflammatory activity, but even months or even years after the lesion manifests, a subset of lesions have this persistent inflammatory activity. And one feature of that is that these lesions are sometimes surrounded by a rim or a ring of microglia, which are the innate immune cells of the brain, or the central nervous system in general. And those cells, individual cells, are too small to image. No, an MRI can't identify an individual cell or even a sheet of cells. It's just too small. However, because of their native physiology, these microglia pick up iron, and iron is magnetic. And because the MRI is built on magnetic fields, the iron disrupts the magnetic field, and we can measure that. And so this paramagnetic rim lesion refers to the paramagnetic rim of iron that exists around the lesion that we know is related to microglia. And we know that the presence of these lesions is associated with less good outcomes. So patients with a lot of pearls tend to have more progression independent of relapse activity, and higher disability over time. The causation is not worked out, but there is a very strong correlation there.
I think you and I were at a meeting where there was a debate about how much of a ring has to be there to call it a ring or rim. Is there any consensus on that now?
This is a little bit like the conversation we just had about central vein signs, where there's an implementation issue that needs to be overcome. These paramagnetic rim lesions are really visible on high resolution susceptibility weighted imaging, quantitative susceptibility mapping, and those T2 star images. And you have to look at a combination of the magnitude image and the phase image. So it gets to be somewhat technical. What defines a paramagnetic rim lesion really depends on the resolution of your scan, and that's still really being worked out. There's general guidelines about the rim needs to cover more than half of the lesion and needs to be visible on more than one imaging plane. As these tools get rolled out in more kind of widespread use, this is going to be solved. It's a trade-off between sensitivity and specificity, right?
So just to be clear, so these paramagnetic rim lesions signify, tell me if I'm wrong, phagocytic cells that have phagocytosed cells that have iron in them that are probably dead. And these are mainly microglia and maybe macrophages, monocytes. Is that correct?
Yeah, and you bring up a really good point that we're imaging the iron, not the cells. And so one limitation of this is that the cell that phagocytized the iron may be dead or moved on, or, and what we're imaging is the iron. And so we don't really know what that cell is doing at that point. How much that will matter is to be determined, but that's the limitation of the technique.
The slowly evolving or slowly expanding lesions, that's yet another type of lesion that seems to be involved in progressive MS. Can you tell us more about that and how that's defined?
Yeah, so these slowly expanding lesions, of all the things we've talked about, the most straightforward name, which is they're lesions that slowly expand. And so what has been noticed for a long time, especially after moving to 3 Tesla MRIs and kind of millimeter or sub-millimeter resolution on the scans, was that some lesions tend to just grow over time. And this is subtle. We're not talking about a lesion that doubles in size in a year, because that's more than likely just a second new lesion that closely approximated the first. We're talking about lesions that grow, a couple of percentage points in size per year, and over time can become quite large. These lesions in histopathology kind of correlation studies also have increased inflammatory activity in them, and so they're considered a chronically active lesion, just like the pearl was. Interestingly, at least the best evidence that's available now is that not all pearls are slowly expanding, and not all slowly expanding lesions are pearls. And so that Venn diagram actually overlaps much less than you might expect. And this has prompted a lot of thinking about what constitutes chronically active lesions, and what is the taxonomy of lesions, and how, which are bad, which can we modify with treatment. I think we're on the cusp of having more brain penetrant disease modifying therapies here in the next few months to a year. So these are all questions that we're going to have to figure out. I don't have a concise mapping of this onto clinical outcomes or even pathology at this point.
So do you see pearls and slowly expanding lesions as being maybe used as secondary or tertiary endpoints in future studies?
I think the pearls in particular have a really tight relationship with an underlying cell type that we know to be involved in the disease. We talked about the hurdles, but of all the hurdles in biomedical science, these are overcomable. It's a relatively easy to acquire marker, and especially as we start looking at more diverse kind of targets within the MS landscape, these might be a really fast and efficient way for investigators or drug companies to screen therapeutic molecules in a way that's faster. Something akin to the GAD enhancing lesion for relapsing MS. For progressive MS trials, we need our GAD lesion equivalent, right? That was extremely useful for developing relapsing remitting drugs, and we're still looking for that. I think pearls have as good a chance as anything of being that. The slowly expanding lesions, and this is just my opinion, are a little bit harder because it's a noisier measure, and it's only defined longitudinally. You have to have multiple scans, and scans, a year or two apart, in order to identify these really robustly. At least for the purposes of phase 2 trials, that's not entirely compatible with the idea of getting an early readout. I think pearls are probably more likely to enter the therapeutic landscape compared to slowly expanding lesions, but I think from a biology perspective, they're both really important.
Let's hope that pearls turn out to be as good as gadolinium enhancing lesions for early phase 2 trials. So let's move on to your research. You do a lot of PET imaging and couple it with MRI in some places. What are you doing? What are you excited about?
We do a lot of PET imaging, and so just a little bit of background about the way that the tool works. So instead of the machine, the scanner, doing something to the person and creating the image, the way PET works is we inject the patient with a drug that is radioactively labeled. For humans, it tends to be both a carbon 11 or an F18. However, there are a whole range of isotopes that are used. But these drugs bind a target. They're a drug just like any other drug, and they bind a target with known specificity or sensitivity or kinetic profiles. And then over time, those drugs undergo radioactive decay. And through the miracle or magic, depending on your perspective of physics, we're able to reconstruct an image from those decay events. The images are increasingly high resolution. We're talking handfuls of millimeters at this point, which is, for molecular imaging in a living person, is quite good. And you can ask questions about biology with molecular specificity, but it all depends on what your radio tracer is. The MS field is dominated right now by a set of radio tracers that bind TSPO, which is a protein on the membrane of mitochondria that's very highly expressed in microglia. And so you can image the numbers of microglia in a person and watch those numbers, and depending on your tracer, maybe look at the activation status of those microglia. We've been involved in others have done kind of the obvious or the very straightforward thing, which is looking at these pearls that we talked about. We thought they're microglia. The pathology tells us they're microglia, and it turns out that the PET verifies that you can actually image this increased number of microglia at the rim and of the lesion. And PET adds the advantage of now measuring live microglia as opposed to the iron that's left behind. One of the really special things about being at WashU and being at a real powerhouse radiology and especially nuclear medicine institution is that we have, and I have the pleasure of working with a lot of really talented radiochemists who have been developing new tracers. And so one of the tracers that I've been fortunate enough to be a part of the development of targets a protein called S1P1 or S1P receptor 1. And people may be familiar with that because that's the target of the S1P modulator line of drugs. And so we know that this protein is involved in extravasation of lymphocytes out of the lymph nodes. That's the kind of putative mechanism of action for its relapsing benefit. But these drugs also cross the blood brain barrier, and S1P1 in the brain is required for inflammatory demyelination. It has a lot to do with how oligodendrocytes respond to demyelinating events and attempt to remyelinate, and the list kind of goes on. And so we've been translating that tracer over to humans. And so it's been really rewarding to be a part of that process. We've taken a drug that was developed at WashU, it was imaged in animals for the first time. And, now we've published the first in human studies, a lot of the kind of technical bookkeeping work that needs to be done to bring a new tracer to human use. And now here in the next few months, we're going to be reporting out on the initial multiple sclerosis trials of that drug. And we're really excited to share those data.
That is exciting. And just to remind our audience, S1P stands for sphingosine 1 phosphate, and the drugs that Dr. Brier was referring to that are used in the clinic are things like fingolimod and the other sphingosine 1 phosphate receptor modulators. I mean, this sounds great. So also, WashU recently got a 7 Tesla MRI, and I don't believe we're using it clinically yet, but I know you're involved, very much involved in its development and use here. Can you tell us a little bit about how that's going and what you expect from a 7T versus 3T?
7T refers to the magnetic field strength of the scanner. And I think the thing that most people who are kind of in this space recognize is that when we went from 1.5T to 3T, the image quality got much better. As you go to 7T, you can think of kind of the field strength as your budget to do things. You can spend that on resolution, you can spend that on signal to noise, you can spend it on separating resonance peaks if you do spectroscopy. There's a whole bunch of things you can do when you have a stronger magnet. I don't think it's unfair to say MS is probably the most straightforward application of this higher field magnet, because all of the lesion types that we were just talking about, the central vein sign, the paramagnetic rim lesions, are all susceptibility imaging based. And susceptibility imaging is directly dependent on field strength. So if you increase your field strength, you get better susceptibility weighted imaging. That's just the facts of the physics. And so when you do these scans looking for central veins, you can find them much more easily on a 7 Tesla scanner, both because it has a higher resolution image, but also because the actual signal that you're looking for is much stronger. We've scanned an MS patient now in our 7T scanner, whereas you can see maybe about half the lesions have central veins at 3 Tesla. The vast majority of them have those central veins at 7 Tesla. And so it's just going to make that biomarker even better. That's a real strength of our institution and our MS center.
So is 7T the limit of how far we can go in terms of magnet strength in human imaging?
And you would be better to tell us this. Anne got scanned in our 7T, and there's you start to get to the physiological effects where when you put somebody in the scanner, you have to roll them into the bore of the scanner, and you have semicircular canals, and something about the right hand rule from physics causes a current to be induced. It makes people dizzy. That can be uncomfortable if you're healthy. You could imagine if you had some kind of vestibulopathy, that could be really bothersome. The other thing is that the bore size just gets smaller, or tends to get smaller as the field strength increases. And so the short answer is no. I forget where exactly, but there's a European group that's working on I think a 9.4 Tesla scanner for human use. We'll see. We'll see if people can tolerate it, or how it goes. It's to be seen. I may look back on this in 10 years and regret saying this, but I think there is some maximum kind of usable field strength, because 7T has all these great things that we just talked about. It has a lot more artifacts to deal with because of that really high field. Bone air interfaces are more troublesome and things like that. So there is some trade-off. I'm not saying that there's no application of ultra high. I don't even know what we call it anymore. Ultra high field. It gets more and more complicated as you get higher and higher.
Thank you. And for those listeners that want to know the feeling when you go into these 7T, since I was a control in some of these studies, they move you in very, very slowly in order not to make you dizzy. However, one still feels a little bit like they're on a tilt-a-whirl at the fair. And Matt may recall that when I got out of it after the scan, I was leaning toward my right and sort of walking into the walls on the right for about 10 minutes, but no apparent long-term consequences. I'm excited about that imaging too. Where do you see your research going in the future?
I think there are a couple of things. We're really focused on what drives progression, especially early progression that we know is so devastating over the long term. What are we not treating? What component of the MS pathological process escapes, B cell depletion or escapes any other modality of seemingly high efficacy therapy? And then I think PET molecular imaging in general has the power to kind of identify subtypes or identify subgroups. So, especially as we have more and more treatment options, identifying the best approach for an individual or identifying times at which they can switch from one modality to another. Maybe we'll be in a world where we B cell deplete people early on and then they switch to some other mechanism of action once they're kind of induced. Tracking that process, tracking inflammation, tracking metabolic stress or oxidative stress, those kinds of things is I think where we're moving. And I'm really excited to see imaging kind of guide treatment, not just guiding diagnosis.
Yeah, that will be fantastic. Well, it looks like we come to the end of our time. Today, we've spoken with Dr. Matthew Brier, who's an assistant professor of both neurology and radiology at Washington University in St. Louis. And he's told us some exciting things about new imaging biomarkers, including the central vein sign, which is really ready for prime time now, and then paramagnetic rim lesions not far behind that may be associated in particular with more progressive lesions and with slowly expanding lesions and what's happening in the PET field. I want to thank Dr. Brier for taking part here today, and I want to thank all of our listeners for taking part in listening to In Discussion. This is Dr. Ann Cross.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on multiple sclerosis.